Hey, Dr. Mark Testa here. Dr. Mark Testa here, live, our first YouTube live. I'm excited to be here. Today we're going to talk, and this week we're going to talk about knee meniscus injuries, all things knee meniscus. I want to share with you some information that you might not hear from an orthopedic surgeon, things like nutritional things, exercises you can do. Would orthotics be helpful? Are there appropriate shoes or supports? We're going to talk about all of this over the coming 5 days this week. I want to make sure, though, that if you have a knee injury, that you consult with your physician, and that this webinar, this YouTube live series over the next few days is going to be informational. I'm not here to diagnose or treat any kind of conditions. I'm not making treatment recommendations. I'm not endorsing or creating any kind of claims. So let's just be clear on that. But I do want to share with you all the information about the knee meniscus and how you can maybe take care of this yourself, maybe avoid unnecessary surgery, find a non-surgical solution, and help you remain active and functional in your life. So let's go ahead and get started by talking about the knee anatomy. The knee is really an amazing structure. It's a long, very long lever because we've got two long bones here, the thigh bone or the femur, and then below it, the tibia. So these two bones make up the knee. You'll see the fibula here on the lateral side, also involved in knee anatomy and knee structure, and connecting the fibula and the femur here is the lateral collateral ligament. And on the medial side is the medial collateral ligament. Now, the interesting thing about the medial collateral ligament, it also attaches to the medial meniscus. So kind of interesting here. Now let's go ahead and take a look at what the meniscus looks like here. This is a pretty good top-down view. The meniscus sits on the tibia here. The lateral meniscus is more O-shaped, and the medial meniscus is more C-shaped. The meniscus on the medial side is injured about 3 times more frequently than the lateral meniscus. That said, the lateral meniscus does get injured frequently with ACL tears. Additionally, on the lateral meniscus here in the back, we have the Popliteus muscle that's involved in knee function and unlocking the knee and getting up and down. And so there are muscle attachments, the Popliteus on the lateral side, and the medial collateral ligament that attach on the medial side to the meniscus. The meniscus is got a depression in it to kind of create more of a socket for these condyles of the femur to sit in there. So there's a lot going on with these structures here. The meniscus is obviously a joint spacer, so we don't have bone on bone rubbing and causing damage to the bone, or on the ends of the bone is what's called articular cartilage, and so that is protected here as well. The meniscus acts as a shock absorber and is made of a tough fibrocartilage that's strong and elastic and helps disperse weight, force, and friction. For example, each step we take creates 4 times the body weight of force across the knee. So this thing is very protective of the knee and degenerative changes of the knee, and really, when intact, can really help the knee maintain health. It's also involved in load sharing, so medial and lateral weight shifting is important with the meniscus, and in joint stability. So let's talk a little bit more about the blood supply of this thing, because the blood supply of the meniscus is not really robust, leading to more surgeries than one would expect. We're going to talk about that in a minute. You can see here this little line about the outer 1/3 of the meniscus actually has a good blood supply. The remaining 2/3 has a very poor to no blood supply. So the outer part, if injured, can repair itself. to a large extent, depending on your age and the type of tear, but because it's got blood supply, can repair itself. Or in the rare cases that surgery can actually repair a meniscus, that's where they would attempt to repair it by suturing it together. Now, even repairs of this area can fail up to 20% of the time. Once you start moving in with a meniscus tear, the majority of time, 80 to 96% of the time, that tissue is removed from the body. It's just taken away, which in and of itself causes an increase in stress in the joint and can start the whole degenerative process of the knee, leading to knee osteoarthritis. So the knee meniscus injury is probably the most common injury in the knee. There's about 850,000 procedures that are done, largely, as I said, to remove that tissue, not so much to repair it. It's 2.5 to 4 times more common in men than it is in women. And when you have a meniscus injury, there's a 4-fold increase in the long-term risk of developing knee osteoarthritis. And so maybe this is a contributing factor for up to the for some of the 700 to 850,000 total knee replacements performed in the United States per year. Now, there's 2 types of meniscus injuries. One is traumatic, and one is more chronic or cumulative going on here. Let's talk about some of the risk factors. Now, with an acute tear, the risk factors are being in a weight-bearing position, so you're standing on it during trauma. And the type of trauma is an axial load, so you're standing on it, and then twisting, right? This acts as sort of a mortise and pestle on that knee meniscus, just grinding away at it. So that is one of the major risk factors for trauma in this axial load and twisting. We see this in sports injuries all the time, like football, like soccer, like rugby, like skiing, and in snowboarding. And snowboarding here in Colorado, I saw a lot of these kinds of injuries because people are sort of twisting the lower part of the board, keeping their upper body stable, or counter twisting up above. I saw a lot of those injuries. I've seen in practice someone attempt to get on a stool and flex really hard and then load that joint to get on the stool, tearing the meniscus. I even saw it here in Boulder, Colorado, in the lotus position, someone kind of being pushed and forced to get into the lotus position during yoga and tearing the meniscus. So these things can definitely get damaged, again, axial and load bearing. Degenerative changes happen as well. And one of the main risk factors is age, right? The older we get, the more we use this joint, the greater likelihood of the degenerative changes. It peaks also in men 40 to 50 years old. And you can find a lot of risk factors such as kneeling, squatting, or climbing stairs, maybe for your career or something to that effect. Other things also, big risk factor is being overweight, a high BMI. All that excess weight and force across that joint can cause it to wear out as well. And it may or may not be associated with any trauma. It could have even started in your 20s or 30s if you did have a traumatic injury and you did have some surgical removal of that meniscus, and now the weight bearing, the load carrying capacity, the shock absorptive protective mechanisms of the meniscus are no longer apparent. So that's what I want to cover today. We covered the anatomy of the knee, the anatomy of the meniscus, some of the risk factors for acute tears and chronic degenerative tears. I hope you enjoyed this. Please like and share this with a friend or a loved one who may be suffering with knee pain and looking for a solution. Please subscribe to our YouTube channel below. Tomorrow, I'm going to talk about signs and symptoms of meniscus issues, treating acute tears, what you can do at home, and other ways to prevent this from getting worse. So thanks for joining me. Again, please like and share and subscribe to our YouTube channel. I look forward to seeing you tomorrow. Thanks a lot. Bye-bye.